Well, welcome everyone and thanks for joining. I'd firstly like to begin by acknowledging the traditional owners of the land on which we meet today. I would also like to pay my respects to elders past, present and emerging. So good afternoon everyone and welcome to the October FightMND Scientific Seminar. My name is Sarah Bennett and I'm the Research Coordinator at FightMND. In last month's seminar, we heard from Dr. Rebecca Sangil, who is our inaugural FightMND Early Career Fellow. Dr. Sangil spoke about a recent submitted publication, which was the result of her fellowship work, where she created a map of the cortex proteome in early MND TDP43 proteinopathy. If you miss out on the talk, it's now available on our website, so you can catch up at a convenient time. So following on from the talk today, we are leaving plenty of time for discussion and questions. So if you would like to ask anything, please use the reaction button to raise your hand and one of our team will enable your microphone and camera and let you know to ask your question. Alternatively, you can also type your question into the chat where our team will be monitoring and read out questions on your behalf. Please note that the chat function is only enabled if you are using the app-based version of Teams and unfortunately doesn't work if you're on the web-based version. Please do ensure that you introduce yourself and where you're from before asking your question. So today we have two speakers and each will be presenting on one of the MND registries that are running in Australia. First up, we'll have Professor Paul Talman, who will be sharing with us the MiNDAUS registry. Professor Talman has trained as a specialist in neurology and holds a PhD from the Walter and Eliza Hall Institute. He is currently Director of Neurosciences at University Hospital in Geelong. Professor Talman initiated the Australian MND registry in 2004, bringing together leading neurologists nationally to build this critical infrastructure. Following on from Professor Talman, we will have Ms. Anjali Henders, who is the Program Manager for SALSA SGC Consortium. Ms. Henders brings over 20 years of experience in the design, management, delivery and evaluation of major human research projects. And has been involved in the establishment and management of SALSA since 2015. We will be moving directly from Professor Talman to Ms. Henders' talks, and we'll take questions for both speakers following the conclusion of both presentations. So thank you again for being with us today. Over to you, Paul, to get us going. Thanks.
Okay. Thanks for the invitation to talk about the motor neuron disease registries in Australia. I'll just share my screen and just tell me, is that?
Yep, all good, Paul, thanks.
All good, okay. So I'm going to talk today about the MiNDAUS registry and also, hang on, let's see. So first of all, what we're going to cover what is MiNDAUS. We're then going to talk about some of the legacy data from the Australian MND registry, or Amanda as it's affectionately known. Then our current and future states of registries, or what we see registries in Australia. So this registry began really back in 2004, but then got reinvigorated with this NH&MRC funding that occurred in 2018, where it was evidence driving policy was the theme. So funded by the NH&MRC, leveraged off the previous registry, some key collaborators right from the outset, the SALSA Consortium and MND Australia, Thomas Research Group, MND and me. And as you can see, it really had quite a wide range of stakeholders in the MND field and in the registry field. So who collects the clinical data? We have clinics from all around Australia collecting data currently. So there have been some new additions, Dev Nathani at the Perrin, and Anthony Winkle up at Sunshine Coast, and Lauren Giles down in Tasmania have joined what was the previous clinics from WA, New South Wales and Victoria. And also the Bundoora Clinic in Victoria was a new addition, and Tom Jenkins. So I want to be clear about this because this is some often confusion, and certainly ethics committees get confused. We are not a trial. We do not have an intervention. We're a registry. So we collect information during normal care, whereas a trial's a controlled experiment. Our collection timeframe is indefinite. All individuals with MND are potential participants. The information is collected during normal clinical visits. There is no specific schedule when those have to be collected. We monitor usual treatments. We don't have an intervention arm. The data then is analysed to improve clinical practice, disease understanding, whereas in a clinical trial, clearly it's to see whether there's an effect. The MiNDAUS registry, which evolved from Amanda, added a significant amount it was re-engineered in terms of software through the trial ready framework, through Professor Matthew Bellegarde's group at Queensland University of Technology. We amplified what was already being collected in the Amanda registry and added some other fields which were really important. But what it introduced was that patients can register themselves and they can enter data. They can enter their own data and they can keep their own medical record and their own history of their disease. They can do their own ALS-FRS, easy to access and easy to update. So the clinical data that we collect is the normal metrics. These data points help us track the disease, the progression of the disease in each of the different phenotypes. And I'll talk about phenotypes a bit later. So it's quite comprehensive. This is what's collected from the clinic. Clinical signs are the things that are really important: wasting, reflexes, affected areas, which enable us to see patterns, and then from those patterns to look at cohorts of patients with similar disease trajectories. The patients can add in on their side what their support needs are, what their problem list is, communication, respiratory assistance, assistance for daily activities, medicines taken, all they need to put in about themselves and where they are in their disease. They can also upload their advanced care directives. So what we have currently, as a result of this last 5 years, is a registry that's based in the cloud, securely based on an Amazon server, and it collects data from the clinics. That's the clinicians putting data in and patients putting data in. Patients can see the data put in by the clinics and the clinics can see the data put in by the patients. We can't change their data, they can't change our data, and this is a consent in process. From this, we have the ability to look at survival, milestones, time to milestones, trial-ready cohorts, creation of clinical guidelines which can feed back into the registry. Obviously, this gives us a platform for advising to government and achieve better service provision and reporting on different individuals and their care needs in regional Australia, which are quite different from the metropolitan areas. And we then share the data and have a standing collaboration with SALSA SGC of our clinical data in the registry, which is exported to the SALSA group. This comes from understanding how medical information is collected at the point of care. So hospital medication by event, it's not accessible outside the health service, and it's certainly not accessible by patients. The MiNDAUS registry, which is based in the cloud, is accessible anywhere you are, and it's accessible outside the health service, but you can do it from within the health service, and it's transparent to patients, and they own their health record and can show it to whomever they like. They can also print it out and take it as a printed copy. So the current status of MiNDAUS, which we started a soft deployment of the registry amongst our clinics around Australia. And as of, I think, September, we had 469 individuals who had registered in the registry. with all states apart from the Northern Territory being represented. And we've also brought on Tasmania. Previously, Tasmania was folded into Victoria. We've separated that with Lauren Giles initiating her clinic in Tasmania. They are now a standalone clinic. So they're the total numbers of patients that are registered. Drilling down a little bit on our data capture, as of September 2023, 245 have complete first visit data out of the 469, and 131 patients have had a subsequent visit data entry. So that longitudinal acquisition of data enables us to look at the progression of disease and the patterns of progression of disease, and is obviously very important in terms of developing a complete data set. I want to go backwards a little bit, because one of the things that Amanda did do, which was published in this paper in BMJ Open, was we wanted to be able to phenotype patients clinically, not genotype, phenotype. And it was really based in the fuzzy logic of Susan Mathers and myself in clinic in the late 1990s and early 2000s, understanding through fuzzy logic that patients looked the same and behaved the same, but were different to other patients. That is, we didn't see this as one disease, but a multiplicity of several different phenotypes. We then set about defining those phenotypes as amyotrophic lateral sclerosis of bulbar onset, cervical onset, and lumbar onset, and then flail limb, which was either arm onset or leg onset, and then separating out primary lateral sclerosis, which is a much more slowly progressive disease, but still under the umbrella of motor neurone disease. We codified how you would do that, and we then set up fields when we set up Amanda to be able to distinguish those subtypes. When we've applied that narrative to the MiNDAUS data, so this is data that's been put together from the 245 data sets we have data from. You can see here the colour coding. So if you look at ALS lumbar, cervical onset, and bulbar onset, that's roughly how it should be. That's the right proportion of those phenotypes according to the international literature. There's a group here who remains still undifferentiated at first visit, and then you've got your flail arm and flail leg group and primary lateral sclerosis, and a small group of thoracic onset, which we've defined as a subcategory. So the initial look, and this is too early to really draw any significant conclusions from the MiNDAUS data, but it is tracking exactly as it should, and it's enabling us to define the different clinical phenotypes. And I'll come to why that's important. Now, we enable researchers to acquire the data the same as SALSA does. It has to be, they have to get ethical approval for the project. It's assessed by our governance committee, and then, as you'll hear, the legal agreements and data sharing agreements and research agreements, they have to be in place before the data can be supplied, and it's supplied de-identified. Each person is identifiable by a unique ID number, but the details of the person, the individual, are stripped from any data that is shared with a third party. In scenarios where there is going to be acquisition of the data for clinical trials, and we have 2 requests current from the pharmaceutical industry for access to the legacy data set of Amanda. This is going to really require us to work through significant legal and data sharing agreements, and also the same principle applies. They have to get ethical approval to be able to access the data. One of the tenets that we really based a lot of this, and this is from Catherine Hanson's work, where she sampled our patient cohorts to find out, what their real needs were. And it's self-explanatory. Patients needed something without having to remember everything when under stress and pressure of an emergency admission. And similarly, when they have multiple, motor neuron disease requires a large team to effect clinical management. And there needs to be something that the patient can say, well, here's my data, here's my clinical profile, here are my medications. And again, that has been built into the patient side of the registry. And again, they can print that out and take it to whichever consultation, or they can share that directly via the cloud when they're in a consultation. The future plans for MiNDAUS are really, and it's at the top, this piece of infrastructure is a very difficult beast to fund, because it is the sort of foundation on which you do a lot of other work. And as a consequence, the NHMRC certainly do have funding calls for this type of work, but as you can imagine how competitive they are, and MND being a rare disease, it's not at the top of the list for funders to fund. We certainly can make this a clinical quality registry. So quality improvement, that implies that we're informing practices of best practice, and that has to be iterative. It has to feed back into the clinic and say, this is the national standard, and you can now compare yourself against the national standard. Telehealth probably doesn't need to be embedded, but it will be part of this. We want to link to home monitoring, and I'll talk a little bit more detail about that. And really creating a dynamic health record that can be accessed anywhere at any time for any reason. The final part of that is data linkage, being able to link with other data systems to enrich their data and enrich our own data. I just want to go back in history just a little bit, because it's worth these are where we had the learnings from how to create a registry. So Amanda collected information on 3,160 individuals. They are the total number of registrations. And as I said, it formed the basis for how we designed MiNDAUS. When you look at the frequency, you can see that Victoria dominated the number of registrations through Bethlehem Hospital and Barwon Health. Then South Australia, but every state was represented in a meaningful number of registrations over the duration of Amanda. We also had collaborations with the University of Malaysia, with Nortina Sharazilla, who registered 116 patients, and New Zealand were part of the registry initially. I'm going back to this cartoon again of the different phenotypes. So what we showed, when you break up the phenotypes, the bulbar onset, cervical onset, and lumbar onset, flail arm, flail leg, and primary lateral sclerosis. If you look at the metrics of diagnosis of symptom onset in time, you can see that bulbar onset presents easily the quickest. Well, they really meaningfully all present at the same time, but there is a delay in diagnosing the flail arm and flail leg, and a large delay in diagnosing primary lateral sclerosis. And the same holds true for the initiation of different treatments, ridazole treatment, non-invasive ventilation, and percutaneous endoscopy, gastrostomy. So we've got what I'm showing there is that we've got a way of measuring the milestones that patients hit. And it will be really interesting to see whether these times are different in the MiNDAUS registry, whether the public awareness and the team-based clinics that have evolved have affected a significant change in the initiation of those key milestones. This is a slide again, which we ran these patients through the LS Scorial classification. And for those of you that have used it, this is a very clunky, clumsy, well, it's not clumsy, but it's clunky to allocate people into suspected through to definite ALS. And I think Anjali will allude to the Gold Coast criteria a bit later. This slide really shows that during the time course of the Amanda collection of data set over those 1,600 patients. So this is, we've got more patients in that data since this 2016 publication. But again, the metrics hold up, the proportions are correct, the gender ratios are interesting. Bulbar onset 1-to-1 male to female, whereas the rest of the disease is male dominated. So it picks up that gender equivalence in bulbar onset disease, and median age of onset is as you would expect from other published trials from registries around the world. So effectively what this demonstrated was this cohort of patients that we have accumulated in Amanda, this legacy data set, is very comparable to what is being collected elsewhere in the world. With the help of Laura Zeisser and Alan McRae and Steve Vujic, we currently have a group together, and Ruben van Eyck is joining our group from the Netherlands to do more detailed analysis of the legacy data set. And as I mentioned, there are 2 pharma companies that want to have access to this legacy data for phase 2 clinical trials. I'll come to that at the end of this talk. But effectively, we've put the legacy data, the complete legacy data set through a Kaplan-Meier curve, and you can see that the ALS of bulbar onset is the most severe form of the disease, whereas the ALS arm and leg onset run together, then it's flail arm, flail leg, and primary lateral sclerosis is the most long-lived over the duration of up to 20 years. So the legacy data set, all of the legacy data set is going to be put through a new analysis, which is going to include staging criteria, the King's staging criteria, the MiNDAUS staging criteria, and LS Scorial, but also the Gold Coast diagnostic criteria, which makes it much easier to allocate patients into, yes, this is ALS. And we're going to compare those different groups and see how that drops out using the legacy data set. That's another way of verifying this legacy data set for its use into the future. So we're well into that process of doing that analysis. What I've got here in the last few minutes is where we are and where we're going. So home-based monitoring, voice analysis, plethysmography, body weight, movement analysis, we hope to incorporate into real-time in the cloud that we can use for analysis of disease progression. The intention is to feed that into a care navigator, which at any point in contact with a patient will tell you where they are in their disease. It will give you their Gold Coast criteria, where they sit, and LS Scorial, but it'll also give you the other metrics that help you manage a patient. That care navigator, we hope, will make it possible for the clinician to use the registry in real time to help manage the patient currently. All of this obviously has to have quite a lot of governance. And then we come to curated data sets for third-party investigators. This is going to require quite detailed ethics and data sharing agreements, which are based on the financial use of the data, and naturally acknowledgement in publications. I'm going to finish with going back to 1995. And this was a paper written by Lanny Haverkamp from Baylor College in Houston, Texas, who I visited in the late 90s. And he had curated 1,200 patients, a very meticulous, detailed data set of ALS. Without the clinical phenotypes at that stage, that's something that we added later on. But notwithstanding that, there was painstaking work from Vicky Appel, who was the research nurse at the time under the auspices of Stan Appel's clinic. And I'll just draw your sort of attention to the bottom. He predicted, Lanny was very keen that ALS, this sort of data set, this legacy data set of natural history, could be used in clinical trials, in early clinical trial development, as a mechanism of controls. So you didn't necessarily have to have the number of controls that you might require in early clinical trials, and that it would accelerate clinical trials and even phase 3 trials. That has come to fruition, and there's a link down the bottom here, leveraging AI and digital twins to accelerate clinical trials. So these legacy data sets and the current data set populations, I think as AI evolves and the mathematical models mature, will provide a very good basis to enable patients to have, participate more in the active arm of clinical trials, and certainly help in the development of phase 2 trials. And I think this is an area that's going to rapidly evolve over the next 2 to 3 years. So I'm going to hand over to Anjali, as long as I can stop sharing.
Thank you so much, Paul. Yes, now we'll have Anjali Henders, who will be presenting on the SALSA consortium.
Can everyone see that?
Yep.
Is that working?
Yeah, all good. Thanks, Anjali.
Okay, thank you. So firstly, is that right? Yes. So firstly, thank you very much to FightMND, who invited us to present the SALSA Consortium project today. But before I start, I would like to acknowledge the traditional owners of the land on which I'm presenting from today, the Turrbal and Jagera peoples, and pay my respect to elders past, present and emerging. So it's been around 8 years now since the SALSA Systems Genomics Consortium was established, and 9 years since that initial Ice Bucket Challenge event, which really provided that seed funding for the consortium to be established. So I want to provide an overview of the consortium, who we are, and the depth of the data and range of samples that this resource now holds. The primary aim of SALSA was to establish a clinical data and biological ready resource that is reflective of the M&D cohort in Australia. And although we don't progress specific research questions ourselves, we do continue to contribute to other research projects both here in Australia and overseas, and provide support across a few broader domains to the M&D research community in Australia. I would also like to take the time now to acknowledge those organisations that support SALSA, and that includes FightMND, M&D Research Australia and the NHMRC. So SALSA is a group of clinicians and researchers around Australia, plus a team of international M&D experts, collaborators from the United Kingdom and the Netherlands. And together that brings established ALS researchers, ALS research clinicians, and researchers with an expertise in the analysis of genomics and big data. So just a quick snapshot of the SALSA protocol. So we recruit individuals with an M&D diagnosis, both familial and sporadic cases. And at some sites, we also recruit controls, and these are often non-biological relatives. We collect detailed clinical data, such as the onset of disease and progression, similar to the MiNDAUS registry, as well as time-matched biological samples every 3 months for as long as the consent is valid and people are able to provide that sample. The clinical information collected is an agreed set of data consistent with NCALS, the European ALS Network, and of course harmonised with the MiNDAUS registry. So in total, across each clinical visit, there's approximately 200 pieces of independent data that's collected on M&D cases. The biological sample we most often collect is whole blood, and we collect this at the clinical appointment, but also understand that not everyone can provide a blood sample, and so we also offer the option to provide a saliva sample. The derivatives of these samples, which include plasma, white blood cells and serum, are stored indefinitely under their informed consent and can be accessed by the consortium members and other third parties. So they're used to generate genetic information, as well as developing a resource of longitudinal samples that would be useful in tracking biomarkers present in the plasma and serum, as well as epigenetic information. So really the central theme about systems genomics is to integrate genetic and genomic data to better reveal the intrinsic complexity of biological processes underlying the phenotypic variation of MND. For the SALSA consortium to be effective, we've also had to ensure that we develop a robust research governance framework to ensure the research aims of the projects can be delivered and that the participant consent is upheld. So for a participant, that informed consent manages the ownership of their sample with respect to ongoing inclusion in the project and its aims. At the site level, whether it's a clinical site or a research group, the principal investigators have access to their data and sample collections and can share these where appropriate governance is in place. And at the top tier, which is the consortium itself, it manages the independent ownership of the data and the sample across the sites, and also the access requests by third parties. So just very quickly, just want to go through the MND research portal. This is what we are currently using to manage the governance across all of the sites with SALSA. It allows us to ensure firewalling between the projects and also between any sub-projects across the broader research program. It meets all the current national statement guidelines from the NHMRC and also the GDPR requirements. So one of the really important features of the platform, and this is similar to the MiNDAUS registry platform, was to make sure that there was an easy and clear two-way data flow so that the clinicians and researchers using the portal could easily access their own data without having to make formal requests through the organising team. So we've achieved this by providing dynamic reports around recruitment rates, cohort summaries, individual participant reports, based on longitudinal data entered by the clinic. And specifically, we've enabled geospatial plotting of the participants with the ability to apply data filters to drill down on the cohort. So SALSA has now recruited over 1,000 cases, and there is clinical data from 1,193 individuals, biological samples from 1,162 people, and we've generated genetic information on 1,124 cases. So really the difference between these numbers is that some of the data collection is still in progress. Sometimes not everybody's able to provide a sample, and there are always samples queued waiting to be genotyped. So to quote directly from the initial SALSA grant application, the vision was to build an MND resource to make the most of the technologies that are available today, but also tomorrow. So to establish a be-ready resource. And so just as of last week, we have 1,106 MND cases, which have the full complement of clinical data, biological samples, and genetic information. So taking the numbers from the ALS repository in the American Centers for Disease Control and Prevention just last week, they have clinical data and samples from 1,617 individuals. So these numbers are reassuring in that the resource that SALSA is building is comparable to international efforts. And in fact, with recruitment increasing after the COVID disruptions, certainly hope that we could surpass these numbers and grow to become one of the largest MND collections. So although we have this number of cases in the collection, the amount of data that is collected on each individual differs. And so as a result, in some of the following slides, the ends that I'm presenting will differ away from the 1,193. So as Paul also mentioned, one of the defining features of ALS is its heterogeneity across patients. So they differ regarding the extent of the upper and lower motor involvement, occurrence of non-motor symptoms such as cognitive and behavioural deficits, and most interestingly, the rate of progression of the disease course. So this figure plots the ALS-FRS scores for cases where there is more than one time point of data relative to the onset of disease symptoms. Trying to draw conclusions about potential subtypes of disease using this alone is near impossible. And so building layers of data using the SALSA protocol, integrating biomarker and genetic data will help progress our understanding of this complex heterogeneity. As I said, we have data now from over 1,000 cases, and so really the power and the usefulness of this resource is starting to be realised. So cases have been recruited across a range of clinical phenotypes, providing useful data for the purposes of subtyping and trajectory analysis. But as I said, an important part of the SALSA protocol is to collect those biological samples, and having this resource then allows clinicians and researchers to either use these samples for potential selection into clinical trials or follow-up of gene discoveries and biomarker results. And collecting samples along the disease course really provides opportunities for researchers to study the changes occurring. So the graph on the right-hand side shows the range of biological samples we've collected with respect to time from onset of symptoms. So you can see that the majority of our samples have been collected about 18 months from onset. So the distribution of the samples with respect to the onset of symptoms hasn't changed greatly between 2017, which is in red, and the 2022 plot, which is in green. However, what's really important to note is that the median of time has shifted by about 3 months closer to disease onset as a result of recruitment and collection of samples occurring earlier. And that essentially means closer to that initial clinical visit and closer to time of diagnoses. So all samples we know provide information. However, placing an emphasis on collecting samples earlier in the disease course really supports methods being developed for earlier detection. So I wanted to share with you some work that we've done in utilising the Gold Coast criteria, and Paul mentioned this in his talk as well. It was developed really by a group of international ALS clinicians that wanted to develop a simpler diagnostic criteria, and they recognised that ALS was a progressive disorder of the motor system with cognitive, behavioural and or psychiatric abnormalities. So here we've applied the Gold Coast criteria across all of the clinical phenotypes present in our cohort. So our findings support adopting the Gold Coast criteria, with most cases with the classic ALS phenotype meeting the criteria for diagnosis. However, there are some classic ALS individuals who fail to meet the criteria, potentially affecting clinical trial recruitment and involvement. Similarly, meeting the new criteria could affect clinical trial recruitment for individuals with unclassified clinical phenotype. We also found numerous individuals with non-classic phenotypes meet this Gold Coast criteria, and that raises questions around where these phenotypes fit into the spectrum of ALS. With the centralisation of clinical data, we can start data mining really to understand the power of this detailed clinical phenotyping. So evaluating the rates of progression is particularly important for a number of reasons. We know it can impact clinical care plans, patient legacy plans, as well as inclusion into clinical trials. So here we've taken the rates of progression, which are determined by the difference of the ALS-FRS scores between clinical visits, and divided them by the number of months between those 2 points. So clinically, the expected rate of progression is between 0.5 to 1.5 points decline per month. Slow progression is defined as less than 0.5 points and fast as greater than 1.5 points per month. So this is work done by Laura Zeiser, which shows a sunburst plot of 834 MND cases of European ancestry, where each slice represents an individual and each ring is 1 year of disease from the onset of symptoms. So the general trend shows that when the rate of progression reaches greater than 1.5 points per month, fast progression, being a fast progressor, it does not ever reduce. The other thing is that this type of analysis really reinforces the value of having data and samples collected at many times during the disease course, meaning that we can pinpoint when these changes occur and when we have the possibility to understand this biologically as well. So beyond diagnosis, tracking individual disease progression also has the potential to improve patient management and clinical trial recruitment. For individuals in the Queensland Clinic who have a classic ALS phenotype and meet that Gold Coast criteria, we calculated the ALS-FRS scores, sub-scores and progression rates across the disease course. So this figure shows the scores over time for each individual, and it clearly confirms that this disease progression is very heterogeneous, with some individuals progressing very quickly and others very slowly. So to further investigate this, we binned individuals into slow, expected or fast progressing for each year of their disease. And this highlights trends such as the decrease in fast progressors amongst individuals several years into their disease. A conclusion we can definitely draw from this type of analysis is that progression is not linear. Drilling further into the data collected using the ALS-FRS, we investigated if the region of onset of disease drives the ALS-FRS progression. We used the ALS-FRS subscores and plot over time, and we do see that in some individuals, the region of onset does drive the change, with good examples being patients who have lower limb onset, and that's best demonstrated in the lower part of the slide here, where we've taken 4 individuals with onset of disease in the lower limbs. To complement the SALSA initiative and the clinical and genetic data, we've developed the Lifestyle and Environmental Risk Factor online questionnaire. This questionnaire is delivered at baseline, which in most cases is around the time of diagnosis, and includes questions across lifestyle behaviours, past medical history, diet and exercise, and risk exposures. It takes about 30 minutes to complete. And as it's been incorporated into the SALSA protocol at different times across the sites, to date we only have data on 165 individuals. So we don't have specific research questions at this point to address. However, what we have done is we've commenced reviewing the data as part of our general QC processes. So I did want to share just some very initial results with you. So as part of this questionnaire, we asked participants to self-report any existing medical conditions, and specifically any conditions they may have experienced in the 12 months prior to their diagnoses. So on the left-hand side, it shows the breakdown of conditions, with around 40% of cases reporting being diagnosed or treated for infectious and parasitic diseases. And this would include conditions like influenza, gastro, shingles, etc. So cancers, mental health and diseases of the circulatory system, such as cardiovascular disease, have also been self-reported in high numbers. Filtering more specifically into medical conditions in the 12 months prior to their MND diagnosis here on the right, medical conditions associated with parasitic and viral infections and high blood pressure are the most commonly reported in this cohort. Included in the LOEF questionnaire is a section on environmental exposures such as chemical and physical hazards. And although participants are not required to complete every question, we've had 161 responses to the question around excessive exposure to chemicals. So this is a frequency plot of those responses, showing across this small set that there's been excessive exposure to chemicals, particularly with pesticides, accounting for 17%. So the LOEF questionnaire also includes a personal journey section where we invite participants to provide any additional information that they may feel is important for us to know in relation to their diagnoses. And so I've included some quotes from them on the right-hand side here, which provide context for reporting excessive exposure to chemicals, both in the urban and rural settings. So we undertake genetic screening, and we use the DNA from the blood samples on a bead array chip to screen for single nucleotide polymorphisms, or SNPs, generating whole genome mutation data informative for MND onset and progression. So we use data from the Illumina Global Screening Array chip, plus in-house developed panels to report mutation status for the 15 genes, which are listed here on the right-hand side. And this was recently expanded from an original panel of just 5 genes. So where we are detecting variants which have a positive association with MND, we do see that the frequency of that variant in the SALSA cohort is replicating with previous studies undertaken here in Australia, and importantly, in studies where ancestry is predominantly Caucasian. So one of the variants we do screen for is the C9orf72 6 base pair expansion repeat associated with familial MND. And so we've developed and validated the screening methodology within the Human Studies Unit that supports the SALSA infrastructure. So on the left-hand side are fragment analysis traces of samples where we've screened for the presence of the expansion. The reference range does depend on how the assay was developed, and usually the reference or unaffected range does not exceed 30 repeat units. So in our experience, positive cases have repeats well beyond the reference range and are easily distinguishable by this trace here. It's often called a sawtooth pattern. So tandem repeat expansions go well beyond the reference range into the hundreds and even thousands, and are consistent with the onset of MND and or frontal temporal dementia. And it's reported that mutations in this gene account for 25 to 40% of familial MND and about 7% of sporadic cases. So in the SALSA cohort, we've identified 42 cases positive for this variant, replicating the incidence of this mutation in familial cases at 27%. So comparing this sub-cohort of cases to the entire cohort, we see consistency across other clinical phenotyping, including the distribution of the onset region. So at baseline, data is also collected on comorbidities, and of the 42 cases who were CNI-North positive, 25 individuals had comorbidities recorded as part of their primary clinical visit. So the actual number of reports is 50, and that's because some of those individuals have more than one other condition at the time of their MND diagnosis. So we plotted these against broad categories of disease, and diseases of the circulatory system, which include cardiovascular disease and hypertension, are the most common. And that again is consistent with the self-report data in that LOEF questionnaire. So the role of cardiovascular disease in MND is still being investigated, but its incidence in the SALSA cohort is actually low. But interestingly, that actually is consistent with previously reported Australian studies. So on the right, we've mapped the rates of progression for the same set of cases. Comparing them to the entire SALSA cohort, the group of expected progressors, which are the bars in green, which is 0.5 to 1.5 points decline per month based on ALSFRS, actually has a higher frequency in this cohort compared to the rest. So SALSA has actually been supporting the Magnet clinical trial this year, and specifically they have been they've requested the genotyping of a SNP associated with the UNC13A gene, and that SNP, the C allele of that particular SNP, is associated with ALS and FTD susceptibility and may underlie differences in treatment response. So this variant is targeted on the MND genetic screening panel using the Illumina bead array technology, and published data shows that the risk allele is associated with shorter survival in ALS and more extensive cerebral involvement of frontal and temporal regions. So the Australian arm of the Magnet clinical trial is being led by Professor Keenan and is being supported by SALSA infrastructure to undertake the genetic screening of this variant as inclusion criteria for the trial. So to add to the assessment of the feasibility of the trial, we provided current genotype frequencies for this variant in the SALSA cohort, and also worked with MiNDAUS to establish the location of patients across the SALSA sites. Of the current cohort, 141 cases were positive for this homozygous genotype. We did, however, need to refine this further to screen for those cases who may have passed or withdrawn from SALSA, and this reduced the cohort to 663, of which 83 cases were positive for the CC genotype. So this was great. So we were able to provide this immediately to the trial coordinator so that could be on-shared with the sites to initiate recruitment where other inclusion criteria for the Magnet trial had been met. So following on from mining the genetic data in-house for the Magnet trial, we have now developed a Explorer interface on the SALSA website. So this is a public-facing Explorer function which allows the collection to be queried, providing availability of clinical phenotypes, sample availability, and genetic data. So the Explorer results are summaries. We don't provide any identifiable information. And so if you are interested in accessing these data, please go to that website, and all the information that you need and the process is there, and it's easily accessible. So one of the planned key outcomes of SALSA was to increase collaboration between MND groups in Australia. And across a number of collaborative domains, SALSA has contributed and or supported other research groups in progressing their MND research program. In particular, though, one aspect that has been really important for us was to engage with people living with MND, their carers and their families. And we've been able to do this through a number of local events and research days like MND Connect. So in the past 12 months, we have been monitoring the use of that SALSA Explorer interface, and we can see over 70 queries run from IP addresses both nationally and internationally. And it's also been used in the applications to access data and samples from SALSA. And we've had 7 projects approved this year across the research domains of proteomics, metabolomics, DNA variant screening, machine learning, and biomarker screening. And these are some of the institutions here on the right-hand side that we've been able to collaborate with. In recent years, the access to and sharing of this resource has resulted in several publications, and I would just like to highlight this one. I appreciate it's a couple of years old, was published at the end of 2021, but SALSA contributed clinical and genetic data from 467 cases to this international consortium led by the team at the Utrecht Medical Centre in the Netherlands. So this paper has used whole genome SNP data from 29,000 MND cases to identify 15 risk loci that were also shared with multiple traits within the neurodegenerative spectrum. So although perhaps the overall contribution from SALSA was small, what this really does reinforce is the time that we take to ensure that our protocol is harmonised, not only across Australia but internationally, means the data that we're collecting on our MND cases and the genetic data being produced can be directly compared and integrated with data sets collected overseas. I've also taken a snapshot of some of the papers that were published in 2022, where SALSA has provided either data and samples for the purposes of these research projects, and they've resulted in these publications. So the SALSA consortium from the very beginning was focused on systems genomics, which implied a vision of multiple biological samples, longitudinal and generation of multiple omics data. So we want to continue to expand this resource, but the resource is only as good as the participant involvement, and also the contribution of time in the research clinics for recruitment across the consortium is vital. And we know that many people living with MND really want to contribute to research and are happy to provide longitudinal samples. A collection of biological samples independent of clinical data is not that useful, but having clinical data combined with biological and genetic data is infinitely more useful. And so I feel that the SALSA consortium still has much to realise, and I hope we've been able to share some of the successes of the consortium with you so far. And I really do feel that the full power of this resource is yet to come. And so with that said, I'd like to thank all the participants of the SALSA project to date, our consortium members, and very especially the clinical research coordinators at each of the SALSA sites who are involved in the recruitment and consenting of our participants. Thanks very much.
Okay, great. Thanks, Anjali, and thanks, Paul. We have about 5 minutes left for a couple of questions. We had a question in the chat from Mike about, does the clinical data entered into the MiNDAUS registry only come from clinics you named on the Australian map slide or other sources? And Paul, you have already responded that almost all come from 14 clinics within Australia. Sorry, go Paul.
Just on that, one of the things that we would be trying to do is for those patients that don't attend clinics, still to enable them to register and collect clinical data. So that's part of the patient side of it, that we're really endeavouring. If they don't attend a clinic, and we have a couple of people who are in our Plex groups who actually don't attend a clinic, but are contributing data from patient registration side.
Great, thanks, Paul. So if you'd like to ask a question, please use the raise your hand function within the chat, or you can type it directly into type your question directly into the chat, and then we will activate your microphone and your camera so you can ask your question. If you could please introduce yourself so that people can get to know who you are and where you're from before you ask your question. Okay, we have a question in the chat from Tess. Says, my partner has MND. How can we register to be part of the registry? We have just started going into the clinic in Brisbane.
Okay, so that's easy. It's MiNDAUS.org. If you put that into your search engine, it'll come up with the landing page. And on that landing page, there is a mechanism for you to self-register. When you self-register, your clinic will appear in that self-registration pathway, and you just have to click on it to allocate yourself to that clinic. And then that enables the clinic to know that you've got a registration already in place. So MiNDAUS.org is the platform.
Thanks, Paul. And if Tessa's partner would like to register to be part of SALSA?
Anjali?
Sure. So when you go into the clinic, I think there'll be an opportunity where the Brisbane Clinic will offer you a range of different research projects to be a part of, and you'll need to be recruited directly into the clinic. But please do ask when you're in there that you'd like to be a part of SALSA. Yeah.
Thanks, Anjali. And a question from David Berlowitz in the chat. Thanks both, really good data and programs. Are there planned marketing awareness programs for both of these initiatives?
Definitely.
This is David is well aware. This is a resource issue, and the infrastructure to both do the work, develop the programs, but then to market, that's a separate skill almost. But yeah, we're aware that we need to get this out into the public domain, both groups, and we're certainly endeavouring to do that.
So one of the things that we are going to be doing is setting up a subscribe button on our SALSA website, so that any new additions to that page or any new data that's loaded to that site, people can be notified directly. So we're hoping to have that going from the beginning of next year, so that that anytime we make changes, that people can be alerted to that.
Great. I have a question about the environmental survey that you're running. Do people have to be registered with SALSA to participate in that? And we often hear from people with MND that they want to give their history about their disease and what they think has caused it. So is there a way that we can, or what's a way that they can get involved in doing that survey?
Sure. So at some of the sites, the questionnaire is part of the SALSA protocol, but that is not true for every site. So you can actually consent independently just to do the environmental survey. So it partly depends on which site which state you're in, and I suggest that you contact the SALSA site in that state, because they'll be able to provide you with the best way to be able to participate in that survey. And yes, we're very much looking to also to be able to offer it to people living in regional and remote areas of Australia who may not actually come into clinic very often, a way that they can consent online. And again, we'll be hopefully bringing that in the early part of the new year.
Any more questions from the floor?
Thanks. We might wrap it up there if there's no more questions from the participants. Well, thank you again to Paul and Anjali for taking the time to present to us today. It's really great to hear about these fantastic resources that are available. So if there's anything else people would like to follow up with today, you can get in touch directly with Paul or Anjali, or through us at FightMND if you would like us to help you connect. I'm sure there'll be many attendees interested in utilising these fantastic registry resources in their own work. So today's seminar has been recorded and will be available on our website in about a week's time. So if you know any of your colleagues who weren't able to join live today, please let them know that they can watch it soon. Well, thank you again for tuning into the FightMND scientific seminar today. We hope this series has been creating new opportunities and ideas for our research community. We do have one more seminar left for 2023, and this will be held on November the 28th at 12 p.m. Australian Eastern Daylight Time. So we'll see you next time, and thanks again.
Thanks very much. Thank you both
for the opportunity.
Bye.
Bye.
Bye-bye.